It's really exciting to see all of your faces this morning. Thanks for joining. I'm really happy to be here, and I'm going to jump in right away with some discussion. But right before I do that, I just want you to take a moment to yourself and think about, what does the word engagement mean to you? Then I'm going to have you navigate to this website, slido.com. You can also scan that QR code, and it's going to prompt you to enter in a word or just a couple of words, maybe a synonym that's in your head, something that signifies what the word engagement means to you. It will give you the option to put in a few thoughts if you'd like to, but just take a moment to do that for me. Once I've got enough of you typing, I'll start showing some results. All right. This is great, right? If we had consensus around what the word engagement meant, right, we wouldn't have talks like this that get into the complexities of engagement. I'm seeing a lot of things like interaction, participation, but also some underlying things that might need to be, necessary for engagement to even happen. Things like commitment, interest, value. I'm seeing some things like shared learning, joyful, absorbing and implementing, adoption, acceptance, interactions, yes, invested, right? So there's lots of things that we think about when we think about engagement. And I wanted to start off with something like this just to highlight the very many things that people mean when they say the word engaged or engagement, because this word actually comes up a lot when we're developing mobile health tools, interventions, things like smartphone apps and wearable sensors and the like. And if you're not asking the question, what do you mean by engagement? You're going to talk past each other, you're going to miss things, and you're not really going to get to the heart of what you're trying to accomplish with your mobile health tool. So thanks for participating in that. Let's switch over to some slides. My primary objective here is really to just get you all talking about engagement, so that when you do go into your interactions with each other and even beyond in your own work, that you actually talk about what it means to be engaged, what it means to be engaged to accomplish your goals, and how you can get from point A to point B. So like I said, my main objective is just to get you to realize that you need to talk. And by doing that, I'm actually going to walk you through some case examples where myself and my team members, my collaborators, have thought about engagement, tested engagement, had some missteps with engagement and things like that. I also want to spend a little bit of time on thinking about context, the context that we each live in, and how we pull someone's engagement into what it is that we're developing or what it is that we're wanting them to attend to. I'll talk a little bit about testing, but mostly refer you to other talks that you either already have seen recorded through this program or that you will see later, so that you can sort of connect the concepts that we'll talk about today to some methodology for testing. And then we'll go through a summary of all of that. But I first want to start with this story because it's one of my favorite. And it's really a story about engaging people, in this case physicians, in the best practice in their area. So there was a group of physicians within a healthcare system that wanted to essentially get their physicians to adhere better to some clinical guidelines around treating obesity. And to do that, they thought the best way to engage their physicians was to just remind them. Surely they know what the clinical practice guideline is. They just need to be reminded and maybe flagged to know that they're about to see a patient that meets the criteria for getting some counseling around obesity. So they built what's called a best practice alert. And if you've worked in a healthcare system before, you should know, and if you haven't, you should know that there are often a bombardment of these kinds of pop-ups that occur when you are in an electronic medical record dealing with patient information. And it's generally to remind you or to flag some action that the system would like for you to take, usually to adhere to best practices. So this particular one pops up every time they see an individual who meets the clinical practice guideline criteria. And so what my colleagues and I really wanted to know was like, well, how effective is that? Because we're not seeing it on the referral side, meaning we weren't seeing a lot of patients being seen in, say, the lifestyle medicine centers or other treatment programs for obesity. So we weren't sure exactly how this best practice alert was really being helpful. So we pulled all of the information about how often these best practice alerts were going off, and then what happened afterwards between September of 2016 and April of 2019. And it's important to note here, this is for all providers. It's not one particular specialty or role. So in case you were thinking, well, it depends on what kind of physician we're talking about. It really doesn't. This includes everyone. And what we found was that there were 261 almost 262,000 triggers that went off during this time. And only about 30,000 of them were just acknowledged, meaning they clicked OK and moved on. And about 10,000 of them actually had some sort of follow-up action that was consistent with best practices. This is pretty abysmal if we're expecting a best practice alert to actually do its job. So the question is, what happened here? And I wanted to pose this question to you all, given this kind of information. What do you think happened here? Throw something in the chat, raise your hand, speak up. Why weren't we seeing the actions that we really wanted to see? Why do we have 88% with nothing?
Alert overload.
Alert overload, right? Failure to consider the context, right? When I have 20 best practice alerts, that's being, maybe that's exaggerating a little, in my face, right? Am I really going to pay attention to yours? Yeah, pop-up fatigue, wrong time in the workflow. Excellent, excellent example, right? If this isn't prompting me at the time that I can actually do something, maybe I went into the chart to pre-record something before I was actually seeing the patient. I'm not in that workflow to actually have that conversation with that patient at that time. No easy connected action step in the system. Adam, thank you so much for that, because that's exactly what we found the most when we went back and surveyed folks and then did some interviews. We were finding again and again and again, well, even if I did something, I wouldn't really know where to connect them. There aren't enough referral sources to actually send these people to take that next action step. And that turned out to be a big failure. Good. Too many things on the agenda. Yep. We got other things we got to tackle too. Absolutely. So thank you for all of those explanations. They're exactly right on with what we were finding in some of our follow-up. But the point here that I really want you to take home is that it's not just about reminding people. If you think about how we were trying to engage physicians in this process, the reminder was meant to engage the physician in thinking about what needed to be done for a particular condition. And then the next piece is that that physician then needs to engage that patient into actually taking the next steps and engaging with those next steps to actually get treatment for obesity in this case. So there was sort of this cascade of things that was intended to happen from this one little prompt. Reminders may not be enough. Pings, prompts, text messages, etc. Those small things to have an effect on a large cascade of follow-up behaviors may not be enough. We need to be thinking about the context in which they're happening. Good. The next example I want to go through is really when I think about and when I talk to people on the business side of things or marketing, we're often talking about engagement, and what they're really getting at is trying to elicit some sort of desired behavior. So I brought up this example because this is something we did in our group on that side of things. And the question that drove this was, how do we attract more men to engage with our recruitment materials and garner interest in our weight loss program? If you're not in the area of obesity and cardiovascular disease prevention, you may not know that we get an overwhelming amount of women that like to enroll in our trials, and we are often quite behind our recruitment targets for men. So this was a question really that we explored with some of our marketing colleagues to try to increase the interest in our weight loss programs through our recruitment methods. We took an approach where we tested 4 different modalities and then 4 different messages. This is a nice blend of digging into marketing strategies, using different types of modalities to reach out to people, meet them where they're at, so to speak, and the behavioral science around reasons why people engage with health-related material. So we tested both modalities and messages. From here, though, I'm actually just going to focus on the modalities because it turned out it didn't really matter what kinds of messages we were sending to people. And I'll walk you through this a little bit. We did several waves at this point, but this depicts 2 waves that we did. In the first one, we were comparing using a mailing list to target men, using an emailing list to target men, using Facebook and Spotify. And what you can see pretty clearly here is 2 main things. One is that we got the most clicks from emailing lists, but when it came to actually completing our screener to get into the program on the website, we had more people from our mailing list. So our overall percentage of mail web screens was higher here. We would consider that to be our highest performing modality. But then when we kind of look at the big picture, what we're seeing is even more interesting is that the cost per click or to get them through to the web screen is actually really cheap for Facebook. So in this particular study, we tried to control for the reach of each of the modalities, meaning the same number of people received the advertisement. So Facebook didn't get as many clicks, but it sure was cheaper once they did trickle down into the web screen. So for our second round of this, we actually just pulled the mailing list and Facebook as our most successful and our cheapest modes of advertising. And what we're finding here, we didn't control for reach in this case, we just let it rip for the same amount of time. Again, we have this really great conversion rate from mailing lists, but overwhelmingly, Facebook is still our cheapest option. And if we had right-sized it to the same amount of cost, we would actually be doing better. So now we're focused most of our efforts on Facebook. And just in case you're interested, this was the one that actually won out of all of them. We've done testing with different images. We've done testing with different headers. It seems like men really like to be told exactly what to do. Take action today. That's the big takeaway here. But I wanted to show one other way of testing what we mean by engagement. But we're often asking people, right, in our health outcome studies to do activities that will produce the health outcomes that we're interested in. And what we know about adhering to prescribed treatments for health are that the odds of good medical outcome triples in when we compare good adherers versus bad adherers. And that perceived susceptibility, that is my perception of how at risk I am for having poor outcomes from a health outcome, is associated with being adherent to the thing that's been prescribed to me. And the simpler the behavioral requirements are, the more likely I am to be adherent to them. And this is certainly borne out in the data that we see. For example, something like mammography, where you're going in, I wouldn't say it's simple, but it's a one-shot deal. You go in once a year, you get some pictures taken, you leave. A lot of press is done around breast cancer risk. So there may be many women that feel like they're highly susceptible to breast cancer. And so we see adherence rates around 80% in the general population. As we get more complicated, though, things like colorectal cancer screening, we see 63% adherent. It's a multi-step process in order to get cancer screened. Medication's kind of a mixed bag. Really depends on what the medication's for, how you feel when you're on it, how you feel when you're off it. So it's about 50% for any kind of medication that you would provide. And you can see some of the heterogeneity that we tend to see here in things like hypertension medication, which is a condition that you don't often have symptoms from. So you can't tell the difference in how you feel based on when you actually take the medication and when you don't. The point is here that we can take away from when we're talking about engaging individuals in health behaviors to see desired outcomes is that if their perceived susceptibility is high and if the behavior requirements are simple, we see higher adherence rates. But more than that, we also need to be thinking about how these concepts and constructs really play out when we're designing interventions to produce desired health outcomes. This is a very simplified example of a text messaging component or a mobile health app component, and how we anticipated that it would affect things like self-monitoring adherence, that is tracking things like diet, physical activity, and weight, and how that would ultimately affect weight loss. And I would say that generally, I highly recommend that we start to think about and that we always put together some sort of conceptual or theoretical model for how we anticipate our mHealth components to actually affect the health outcome that we're interested in. In this case, we wanted the message to target supportive accountability and facilitation in order to affect self-efficacy, such that it would increase self-monitoring adherence, which mediated the relationship between self-efficacy and self-regulation to produce weight loss. I'll take this back to our very first example. If that group of individuals that put together that best practice alert had really thought through how their component or how their reminder was really intended to have the outcome, and had really thought about what predicts human behavior, for example, in between these two things, they may have realized that they needed a more robust approach in order to see the outcomes that they really intended. Now, we know from behavior science quite a bit about what facilitates behavioral adherence and self-management, especially in the health area. Things like behavior change techniques like goal setting, self-monitoring, providing feedback, problem solving about barriers, reinforcement, social support, the list goes on. And I'll refer you to an article from Susan Mickey and her colleagues in the Translational Behavioral Medicine from 2018. She does this nice scoping review of the different types of behavior change techniques that we use in health-related behavior research, and how we could be evaluating them better so that we can actually know more about what works and what doesn't, because there's certainly a dearth of information there. But we need to be thinking about, how this plays out in the mHealth space, because there certainly are a whole lot of apps, wearables, websites, et cetera, that say that they help people do these things or engage in these behavior change techniques. But we don't actually have a lot of data to support all of the ways in which this is really helpful. And I'm going to go through a couple of examples. The first is the engaged weight loss study. I won't go through all of the details of the study, but essentially it wanted to compare what happens when you give people a self-guided program for weight loss versus when you give them tools like typical paper and pen self-monitoring, which was typical at the time, with a little book where you can look up things like dietary nutrition facts, or technology like a smartphone application in order to track things like physical activity, diet, and weight. And what we see here is that when we looked at adherence to self-monitoring, really the individuals that had technology were more adherent than the people that had the standard paper pencil versus the people that were just on their own. And this kind of finding held out for self-reporting of physical activity, for reporting food items consumed, and for tracking weight. And so at the time, and really today, we see that the more self-monitoring you do, the more weight you lose. So this would say that, oh, we made the self-monitoring aspect really easy with the technology, we should see better weight outcomes. That was not the case. So in this particular study, there was no difference seen between our tech and our standard groups. And in fact, our standard group lost more weight at 6 months. This is just a different way of seeing it. And as you can see, this finding actually continued until we got to 12 months. And you can see that almost, it seemed like people in the technology supported group had actually started to gain weight during their maintenance phase. So what do we think happened here? And I'll ask you to do the same thing. Speak up, raise your hand, throw it in the chat. What happened here? If technology was supposed to make something like self-monitoring easier, and everything to date had said that self-monitoring was supposed to help with weight loss, why didn't we see it pan out that way here? It's a thinker. People abandoned the technology. Yep, perhaps. App fatigue. Any other ideas? It's a thinker. We certainly spent a lot of time trying to unpack this one. Participants saw diminishing returns in value. Yeah, why would that be, right? If we're expecting self-monitoring to help with weight loss, we really need to be thinking about why that is, right? What is it about self-monitoring? Is it simply that I'm writing it down, that it's somehow magically producing weight loss? Probably not. There's probably a cognitive process going on there. Maybe some learning, for example. And how long does it really take to learn the types of foods that you can eat in order to control your weight? We could see that people stop self-monitoring over time. And certainly you would have to look into the data to realize that. New apps, updates, sure. Yep, self-monitoring might keep people more responsible for tracking their weight loss, sure. Yep. We also thought at the time that perhaps there was sort of this ceiling effect, meaning, sure, maybe self-monitoring helps at some point, but at a certain point, maybe you don't see as much of a direct correlation between self-monitoring and weight. Maybe there's a bit of a ceiling effect there. The other thing I'll point out is that we also have some data to support the idea that sometimes you actually retain knowledge or learn better when you're writing things down on paper and pencil. It certainly is a lot more effort to write something down with paper and pencil and look things up in a book, but perhaps you're retaining that information more. And maybe the technology is making it easier. I think we are starting to see some of that pan out in some of the literature around taking pictures instead of actually searching for the foods that someone is consuming. So there could be lots of explanations for this, but the point is that we should be thinking about those things, and we need to make connections between the strategies that we're using and the health outcomes that we're hoping to affect. Let's go through something that's a little bit more complicated here, and we drilled down a lot into some engagement patterns that I'll explain through this study called NUU, quite a bit more than we had in our prior trials, mostly because we had the data available to us. I will say for a study like Engaged, we didn't have near as much things like time spent in the app and app log data as we do now, primarily because it was one of the first smartphone studies done, and you just couldn't collect that kind of data without significantly affecting someone's battery life, for example. But now we can. And so we started to collect pretty much everything we possibly could in this study called NUU. Now, briefly, just so you understand the context, we recruited 303 incoming freshmen at Northwestern. This was a cluster randomized design that randomized incoming freshmen by dormitory, stratified by dormitory, to a 2-year multi-level intervention. And it targeted one of two things: heart healthy behaviors, which we called the cardiovascular health group, or they got other health behaviors targeted that had nothing to do or were not implicated in cardiovascular disease, and we called that our whole health group. All participants received an app and social media in order to help them to self-monitor the behaviors that they were assigned to target, and to deliver some health-related information. We did assessments at the beginning of their freshman year, at the beginning of their sophomore year, and at the beginning of their junior year in person. And our outcome in this case was AHA's Simple 7 composite score. If you follow this literature at all, you'll know that now they have 8. They've added sleep. But at the time, the 7 outcomes were weight, diet quality, moderate to vigorous physical activity, smoking, blood pressure, cholesterol, and glucose. This just gives us a breakdown of what behaviors we were really targeting and what kinds of app functions each of the groups could engage in. So for the cardiovascular health treatment program, they were tracking things like smoking, diet quality through fruit and vegetable intake, physical activity, and their weight. They were given features like integrating their schedules. They had to answer weekly behavior questions about their target behaviors. And again, they were given social media and some self-monitoring modules. They also received some text message recommendations as part of that treatment. And I should say that everyone was incentivized in some way by receiving like Northwestern branded swag, which they said was really interesting for answering all of their weekly behavior questions. And then they were put into an annual raffle for large cash prizes. For our other condition, though, we had them track their sun safety, safe sex, safe travel, and hydration. They got similar things related to their treatment condition. And a few months in, we wondered, how are our students engaging in the intervention? That is, are they actually doing anything that we've asked them to do within this app? And I'll say at this point that we spent a little over a year in co-creating these app functions and the interfaces and the modules and the logic behind them with students and with a lot of different student groups. So we had a lot of user-centered design work happening all the way leading up to the launch of this trial. So when we saw this graph, where in our first 2 months where everyone was enrolled, that less than 30% were really engaging with our app, we felt really defeated. So we actually worked with the students to improve the app and implement some additional retention strategies to try to rescue this study, because we really felt like, well, if the students aren't engaging with the intervention, they're not getting a dose at all. This was the only way in which we were interacting with them. There's no human intervention component, and so we really needed to do something here in the middle of the trial. You can read about all the trials and tribulations of changing your intervention during the course of the trial in this paper cited here. But just briefly, some things that we did with the students were update the home screen so they could see their schedule a bit better. That seemed to be a main driver of getting people to this app. This population was less interested in the health outcomes we wanted them to be interested in. So this was a really critical piece, is making this more front and center. They also wanted to track things like happiness and stress alongside their health behaviors, two things that they cared more about. And they wanted easier ways to track. So we gave the whole health condition something called a Hydro Coach, and the cardiovascular condition a Fitbit. We also added incentives in a slightly different way. Students reported that they would be more likely to do something if they were going to lose money than gain money. That might be just the Northwestern students, not sure, but we gave them a bank of money and they lost money every time they didn't do a desired behavior each day or each week, depending on the behavior. They also wanted to be able to see their progress on their health goals sort of side by side with their stress and happiness, so they could see how they varied together. And they created this little bubble graph in order to do that, so that they wouldn't have to go to the individual pages. They could also go to this more merged data interface. And then we had, again, some additional weekly questions that they were asked related to stress and happiness. And just briefly, what I'll say here is that what we showed was not just increased engagement in the cohort of students that we had already recruited, which is represented by the blue and then the green. So you can see the blue lines, they were sort of not terribly well engaged in the intervention, but once we made those app changes for the fall, you see an increased engagement in that green, in that purple. And then the green represents actually our second cohort of people. So the people that came into the study with all of the improvements that we had already made. So they were higher engaged all along really than our other group altogether, even though they end up in the same place. Now this is engagement as measured by answering those weekly behavior questions. So self-monitoring their behaviors that they were assigned to. They're also incentivized to do that because if they do it every week for a month, they get some swag. So they were really motivated to do that. But we wanted to look at it in a slightly different way because we know that their attention, for example, is pulled by a lot of other apps and a lot of other things in their context. They're very busy college students. And that's true for the general population too, right? The average American has 80 apps on their phones. About half of them spend 5 to 6 hours on their phone per day. So it's really tough sometimes to capture a participant's attention and engagement, which we feel are the preconditions for behavior change if we're using mobile health or apps as the main way to deliver intervention and to track how they're doing over time. So we can look at this in a slightly different way. We can look at engagement as just how much are they opening the app. So not how much are they completing the things that we want them to complete, but are they even opening it? And here again in blue, we see our first cohort of students who were brought in before we amped up our retention protocol, which you can see a bit of a spike in engagement after that. But we also made app changes and they increased in engagement and sort of tracked along our second cohort that had the better app all along. But we had some additional questions about this because this doesn't really tell us, are the patterns of engagement that are higher now actually producing any kind of behavior change that we're actually interested in, right? Is this following our conceptual model, for example? That is, the things that we're implementing to see better engagement, is that resulting in the individuals actually engaged in the other constructs that we think will ultimately affect the health outcomes that we're interested in? So my computer science colleague and I, Nabil Al-Sharafa, who you'll hear from later today, had some questions related to what is effective engagement, essentially. What does engagement mean that actually results in some sort of behavior change? So the questions for this particular study were, are the participants in it, are they actually engaging just because of the swag, or are there other things that they're doing in the app? And so we thought, well, if they're just in it for the swag, then the activities that we see in the app would just be things like quick opening, quick interactions, really just flying through those behavior questions each week and not much else, right? The second question we had was, how long do participants spend in activities that we would actually like to see? And the two big things that we really thought we wanted to see were self-monitoring, that is actually entering data and tracking or endorsing symptoms during the course of the week, and then reviewing, so looking at those progress screens, either the individual behaviors or that big progress screen that they had created. And then finally, how much of the app use is probably meaningless activity? You've all had the experience, right, of opening your phone and kind of mindlessly going to, some apps, but that's not really why you were picking up your phone to begin with. So we sort of wondered, are our students doing the same thing? Are we seeing a bunch of glances or too quick to be meaningful? And that's what's elevating the engagement. So those were our driving questions in the slides that I'll show you next. The first thing we did that's illustrated in this article is we wanted to know, what categories of activities do students engage in? Can we somehow describe and conceptualize what is going on when they open up our app? So we used head-tail classifications, and we divided the data into looking at reviewing engagement, so looking at those progress pages, and self-monitoring engagement, so actually engaging with the app pages in which you could actually self-monitor, so track or look up foods, for example. And what we found is that there's all these different types of engagement that we see. So we certainly saw quite a bit of glances and checking, but you can see those percentages aren't quite as high as we thought we would see. We thought we would see, 50% of our app opens being just quick glances, interaction times of less than 7 seconds. We see checking, which we kind of conceptualize to be just opening it to check their schedule and closing it. Those interactions happening between 7 and 17 seconds, for example. And then we had some deeper levels of review. So these are interactions where they're spending a bit more time looking at those progress pages, which is really good to see, right? We had brief review. There's 20% of those app engagements were considered to be brief review, looking at a progress page for 17 to 38 seconds, which is not nominal, right? And we actually had almost 10% engaged in what we would call deep review. So spending more than a minute actually looking at those progress pages. And then finally, we had these 3 categories of interaction where they were actually on the self-monitoring pages and tracking their behaviors. And you can see the 3 categories there, where we had 13% in brief interact, which probably means they were going in to say monitor fruits and vegetables, which was probably the easiest thing you could monitor. You're just pressing really a plus button to next to one of the types of fruits and vegetables that you ate. Whereas deep interact was probably something like searching for food. So 4% of those interactions were more than 52 seconds. It takes a bit longer to record things like looking up your food in the food database and indicating the serving size, for example. So it was nice to see this good distribution of activities that the students were engaging in. But is it good news, right? Because our next question really was, sure, it's nice to see this distribution of activities that they're doing, but is any of this actually resulting in any kind of desirable health outcomes? So the next thing we did was to look at the categories of behavior change that students were engaged in. And so for this, we first used those weekly behavior reports to put into this unsupervised k-means clustering. We essentially went through a k-means clustering procedure, which you can see here as depicted by the nice little graphic and the steps. And it essentially reported that we had 4 main categories that students fell into when it came to behavior change over time, as indicated by those weekly reports. And here they are. Students clustered into what we called unhealthy and steady, healthy, steady, decliners, and improvers. And they sort of make sense, right? We had people that came into the study at a fairly unhealthy behavior profile. Their mean on those behavior change figures were low, the variance was low, and the slope was constant. For our decliners, these are people that entered into the study with a low health profile, but there was a lot of variance, but the slope tended to be negative, meaning they're getting worse over time as it pertains to their health outcomes. For healthy and steady, it's the opposite of our unhealthy and steady folks, right? They come in, they have really good health profile as it relates to the behaviors. Their variance is pretty constant and their slope is constant. And then improvers, this is really where we want to see people, right? They come in, this particular category did come in fairly high on their behavior profile, meaning they were already doing a lot of the desired behaviors. They had high variance and a positive slope, meaning they were not just staying steady, they were actually getting better over time. And we had this nice little distribution over here between our two conditions. And although we didn't do statistical testing because it wouldn't have been appropriate here as an interim test, you can see there's like slightly higher improvers in our CVH group, our cardiovascular health group, versus our whole health group, which is what we wanted to see, right? Because our behavior patterns over time that we're interested in, that we clustered for, were our cardiovascular health behaviors. Okay, so how does that relate to app use and engagement? Well, we looked at for each of these behavioral clusters, how much time they spent in the app. And time in app is quite a common metric for engagement, both in the tech community, but also in the mHealth scientific community. So we did that first, even though we knew we wanted to go farther. And what you can see is if you just look at the people that spent the most time in the app, it's actually our decliners. Whoops, not exactly what you want to see, right? Because you think that, right, more engagement with our app that's supposed to make you healthier is actually making you worse. Like, what sense does that make? Okay, but we see some other a little bit of a distribution here between the categories, but this is not really where we wanted to spend our time because we had an idea that there would be something deeper going on, and that's indeed what we showed. So we looked at the number of times they opened the app per week. You can see that folks that are healthy and steady and improvers were opening it more. We also looked at the number of use days per week, and you can see probably not much difference here, but when we look at the proportion of days used per week, we actually see more people in the healthy and steady and improvers groups using it a higher number of days per week than when we look at our decliners and unhealthy and steady. Also, we see a slightly different number of module inputs. We didn't find this to be terribly important at the end of the day. This is really where the story is, and I'll summarize that just to make that clearer. And that is, if you just look at interaction time, you're not going to really find a difference between your improvers and decliners. But if we look deeper into things like how many times they're opening and the number of days per week they're using it, we can kind of tease apart this story. So the people that had high interaction time, but also the highest number of days that they opened it and the number of days per week that they used it were our improvers, and that distinguished them from the other groups. And so we're sort of saying, well, it's not really the amount of time you spend in our app, it's also the frequency and consistency of using our app. That is, you're opening it more days than not. We tried to make sense of this. I don't particularly love this figure, so don't ask me too many questions about it, but I do think what it does is basically make this case that we need to be thinking about what we're doing with our mHealth technology tools to enhance our engagement with the features of the apps or the wearables or the internet site that you're creating, but we've also got to use some behavior science theory because we do have some theoretical models for understanding how to change behavior. And when we think about the usage patterns that we want to see alongside the behavioral trends that we want to see, then we can get at not just adherence and not just engagement, but what we might call effective engagement. And only when we see effective engagement are we going to likely to be seeing the more positive distal health outcomes that we're really aiming for. Okay. So the next question I wanted to ask was, how do we get engagement when we want it? And this came up a lot in the NUU study because, we had this idea that people would be, using the app every single day. It would be their main calendar. We really wanted them to pay a lot of attention to it. And oftentimes, I think intervention scientists and technologists and programmers try to make their technology relevant for the entire day, and they really want their person to be using it and using it more than Facebook. I hear this all the time. We want our app to be used more than Facebook. No, you probably don't, right? We need to be thinking about what exactly are we trying to do and when do we want to engage people, because we're not always all engaged in our health behaviors. And that's evident in the environment that we all exist in. We're having to not just compete with these other things in the environment, and everyone exists in an environment. We also are trying to pull attention during very specific times, right? So if we're trying to then, grab someone's attention within a particular context, we need to be thinking about the context. And sometimes that context is missing in our mobile health development. Context is also mostly ignored by theory. It tends to be, I call it the left-hand box of theory. It's usually sometimes these conglomerate of other contextual factors that probably have an effect on behavior change. Oftentimes we forget that we are asking people to use our technology in the ecosystem of the other technology and environmental cues that they already have going on, and we need to be thinking about that. And it's important to realize that each person lives in their own social ecological context. And if we're not designing for that, we're going to miss something. Attention is a limited resource, right? And we want people to say, have their attention on their child when their child is about to make a dangerous behavior, not be concerned with, did I report my emotions today, right? So we need to be thinking about attention as a limited resource and taking that attention away in the context that is actually going to be helpful for the individual to support their behavior and to support their behavior change for the desired outcome that we have. So I do ask you that as you're thinking about your mobile health projects now and beyond, right, that you also consider the context in which you're asking people to do the thing that you're asking them to do or interact with the widget that you're creating. Here's one last example that I'll show from some work that we did where we did sort of consider context. In this case, we considered time of day, which was really important for this particular study because we were asking people to engage in what's called time-restricted eating, which basically means you don't eat for most of the day and night, but you eat during a very particular window, usually it varies 6 to 10 hours, something like that. And so we wanted to support people in adhering to the small window of time that we wanted them to eat. And we tested things like cues to either eat or stop eating, and messages that were meant more as reinforcement. And we used pebble watches to do this. Man, I miss a good pebble watch. And we assigned some people to get just cues, some people to get reinforcement, some people to get neither, and some people to get both. And what we find here is that the people that got both actually did the best in terms of adhering to the recommendations for the window. And that's interesting because, as you can see here, the people in purple who got cues at the beginning were starting to look like they were going to come out on top. But what you see here is that the people that got reinforcement later in blue, they start to overtake purple. And then the green shows the people that got both. So there's something happening there where cues are kind of supporting the behavior that we want in the beginning, but it's reinforcement that takes over later on. So the question that comes up here is, well, how do we capture that like magic time, right? Where we could have been using cues in the beginning and then switching over to reinforcement once the individual was engaged in the behavior, so that we're not creating situations where they might get tired or habituated to the messages that we're sending, and we can sort of preserve some of that attention based on the science that we have. And I'm not going to go into too much detail, but doing something like that would require a just-in-time adaptive intervention. That is, an intervention that's delivered at the time that it's actually necessary. That is, right, we would have delivered cues until it was the time in which to change over or adapt to the new situation. That is, the person's actually starting to do the thing that we're asking them to do. And then maybe we switched over to something like reinforcement. Now, that's an empirical question. Would that have been as effective as delivering them at the same time? We do have methods to test this. But I won't get into too much of it because you're going to get that content elsewhere. But just to say is, when we're thinking about just-in-time adaptive interventions, we can think about really asking for that engagement at a time that it's actually going to have the outcome that we anticipate. And if we follow a conceptual model that takes into account those things, then we can set up some research questions to actually test our engagement strategies to match on to the behaviors that we're expecting. So in short, adaptive interventions change based on the type of support that's needed, the current need, the context that's around, and you use it when timing is critical, either to hasten an opportunity or to enhance self-efficacy at just the right moment, or to divert away from something that might be risky. Okay, and as I said, we have methods to test this, like the micro-randomized trials. You'll learn about those in other modules, but briefly, we randomize at each decision point when we are wondering about something about the decision rule, or our research questions are about the intervention options that we're delivering. The randomization occurs within person. So each person may have multiple decision points that occur per day. And therefore, that person may receive many different interventions per day. For my technology people in particular, I like to say it's kind of an extension of A/B testing. It's just a lot more rigorous. And as I said, it can answer questions that we have, especially when it's related to engagement. So do the intervention options, like tailored activity recommendations, for example, impact the proximal response or the physical activity that happens in the short term? And does the context impact the effectiveness of the intervention options on the proximal outcome, like the social setting somebody's in, or the location, or the time, or how much of the behavior they had done before? And then you can also ask questions like, when should we prompt people to do a behavior? When is it appropriate to be asking for that attention? And I've mentioned attention quite a bit, but I do want to make sure that I double down on this point, is that you really need to make sure that when you're designing your interventions and the technology that goes along with it, that your juice is worth the squeeze. That is, that your attention that you're asking from people is actually worthy of attention, and that it is actually having the outcomes that you anticipate. And to do that, we really need to be thinking about what pulls an individual's attention, when is attention allocation really worth it, and taking into account that attention is dynamic over time. Text messaging is an excellent example. When we deliver text messages over a long period of time, longitudinally, we know that people habituate to them. Even when you try to change up the messaging a little bit, think about how many text messages and push notifications you get on your phone and watch per day. My watch has been going off this whole time, right? You get inundated, right? So think about what that does over time to an individual and the attention that they're willing to provide you. And then finally, I wanted to say that there are frameworks to help you with this. You do not need to go at this alone. And so I refer to one. I think this is a really nice one when you think about intervening on especially health behavior changes. It may not be as useful if you're designing something like, how do I get people to wear my wearable device? But if you're thinking about behavior change and using mHealth tools to do that, this is a really nice way to be thinking about all the different factors that you need to consider when you're putting together your intervention package and the support tools that go along with it. So in summary, as we started out, we talked about the multiple perspectives that people have about engagement. So it's really important as you're working in teams, because the type of science we do in the mHealth space is necessarily multidisciplinary. You need to be having the conversation about, what do you mean when you say engagement? And then consider that in your design. You really want to think about what role engagement plays in your intervention and in the tools, and designing that role to fit into the context of your typical participant or patient, because everyone has a different attentional capacity and that capacity changes over time. Also, you may need to consider designing for the dynamics of the situations over time. And finally, we have methodologies, and I didn't go through them all, but there are methodologies to test these kinds of things so that you can test them before you actually package them into a multi-component package. So consider using those types of methodologies to test your engagement strategies as you're going forward. And with that, I thank you very much. I can be reached at angela@utk.edu. I'm sometimes on Twitter, but I can be reached there as well. And thank you for your attention today. I can take maybe one question.
Questions.
I had a quick question, and
Sure.
I'm not Alyssa. I'm Phyllis.
Oh no.
Anyway, I just had a question about, I'm interested in incorporating in sort of measuring social connectedness, or the idea of peer support and its relationship to engagement. Do you have any examples that you can provide, particularly looking at peer support or social connectedness using digital technology, and then how does that relate to engagement?
That's a great question and a bit outside of my expertise, but here's what I'll say about that. You do have people here, I think, that are doing more social network analysis types methods, and that's sort of where my head goes first. There's also modeling strategies you can use to look at that and to examine how your dyads are, or so when you said support, I was thinking dyads, but maybe you also mean groups, then affect the outcomes of interest. So I'm thinking about things like actor interdependence models that can help you tease apart, how does one person's action actually have effects on the next person's action on the particular health outcome. Now, how you interweave engagement measurements into that is a really great question. And if you find out the answer, I would love to hear it.
Any other questions, comments?
I have actually a question, but this is more of a like long-term behavior change. So I think a lot of study has shown that during the course of the interaction or the study, they have seen a change in the behavior in the subjects. However, at the end of the study, if they have some follow-up within, let's say, 6 months or 1 year, they went back to their baseline or before the study begins, right? So
Yep.
how do we change this? Because if you think about like how our technology that we are building will impact individuals' life, I think we need to think about long-term scenario. So how can we do this that can help them in a longer term? Can we like modify their behavior that can become their habit eventually? Or is there any work as such?
I'm so glad you asked that question because it sounds like an excellent segue into our next talk about behavior change maintenance. But in terms of engagement, I would say, you do have to think about how you anticipate people engaging in your intervention and your technology over time. I think oftentimes we see apps are a really great example. We see apps being designed where the designers intend for that app to be used for the rest of an individual's life. And I would say that's probably not reasonable, right? So understanding at what point people stop using the technology and how we're continuing to provide them skills, resources, support within their environment is really, really important. And I think Bonnie's probably, if I know her, and I do, she's probably gonna talk about that.